Hi there, I'm John Hillson, and I'm a nurse at Duke Cancer Center, and I graduated with a Doctor of Nursing practice yesterday. And thank you to ROECSG. Pretty well, any paper that's been written in the last 15 years on radiation oncology education has come out of this group. Thank you. So Florence Nightingale actually predates retention and the discovery of X-rays, but for all that, there's been a lack of formal curriculum. The role has been poorly defined, and there really isn't a written scope and standards of practice in the US. There is in Canada and other countries. Until the 1960s, nurses could actually go and learn on the job and then go and become licensed radiation therapists. That's probably a good thing we let that go. But over the last few years, there's been some separation, but the nursing role has been growing. No, that's the laser pointer. Just a few studies that were looking at optimizing radiation oncology nursing. One group after physician education to nurses went and evaluated follow-up nurses throughout treatment, and they noticed a 50% relative reduction in pain scores. There was a group that physicians and psychologists who were training nurses, and then they followed gynecology, radiation oncology patients throughout treatment, regular intervals following. And at the end of the year, most of the patients had gone and recovered baseline sexual functioning, 94% compliance with the exercises, the rehabilitation. SHIELD RT was a study that was actually done at Duke. Julian hung now off at San Francisco. So an AI goes and assesses patients, decides which patients are at risk and who's going to need to have closer follow-up. From there, those patients are randomized into two groups. One group gets seen once a week at usual OTB. The other group gets seen twice a week, once by the attending physician. The second was done by a member of the team. One of the team members was a registered nurse with a bachelor's, some physician oversight, a little bit of specialty training. Fewer ED and hospital admissions, both during and after treatment, decrease in preventable admissions, and the cost of care was reduced. All small studies, but all of them showing some potential. And for all the history, the first radiation oncology nursing needs assessment regarding education in the US, that was only published in 2021. We've got all the authors here. So really, we had senior nurses who hadn't had a lot of time in radiation oncology, virtually no content from school. After they graduated, flip a coin if they got any onboarding. And from there, most of the education was provided by other nurses who presumably were from the same education opportunities. Most learned on the job or from other nurses, but 100% responsible for patient education and coordination of care. One of the interesting parts of the study is they had a 5-point Likert scale. How comfortable are you with the care you're giving based on certain disease sites? Prostate, breast, and CNS, they were rating 4 out of 5. Most other sites, 3 out of 5. So for me, a lot of noise with that. I took the needs assessment survey, adapted it for our location, did a test of knowledge. I hope to do a pre-post test. That didn't come together. And then I developed some online on-demand modules. It was the apocalypse. We weren't allowed to meet in person. And it was very difficult for us to go and get time to go and meet each other on Zoom. So something for the nurses to go and look at as for what their needs were that day. And some of the questions I added. Let's move on to the next one. The previous study had gone and just looked at nursing comfortable, how comfortable nurses were in general. And I know that there was a lot of changes based on acute versus the follow-up care. So Everybody's been onboarded. 100% of the nurses are responsible for education. They were feeling pretty good for this. But then, 100% responsible for education, 80% seeing patients in follow-up clinic, taking the MyChart notes, the triage phone calls, and really not feeling ready. The other part being with 4.17 million radiation-treated survivors in the country, this is also, are the specialist nurses ready to go and act as a resource for other departments or other clinics? And I would have to say, no, they weren't. This is not about me wanting to see nurses go and independently manage any of this. This is about, can they recognize the conditions? Can they go and ask the questions they need to ask in a triage situation, get you the most useful answers, most useful history? And for all that we're all working every day with simulation, how comfortable are you explaining simulation to patients? And CT scans, of course, we're using that a great deal, and contrast reactions being one of our more common reactions in the department. How ready are you for that? And I should say basic radiology is not part of core nursing training. We were looking at purchasing an MR-Linac, and we do get some annual MRI training. Still came out that say code blue protocols around an MRI. There were some knowledge deficits. And we are doing adaptive PET planning. We had a vendor come by talking about giving us a PET Linac. One of the questions I did on the test of knowledge, do you know that a PET scan is nuclear medicine? Asking about that, the nurses actually weren't aware of that. And of course, if you're looking at a PET Linac, you're looking at people with a lot of nursing contributions. They need to have IV access. They need to be injected every time. Blood sugar's checked every time. Over 90% of what we're doing, and this was not the answer I was really wanting to get. And nurses, of course, have a lot of background in chemotherapy and radiation, chemotherapy rather. We also asked the same question regarding immunotherapy. The answers came back a little bit worse, and hormone therapy was a little bit more bimodal. Certain nurses involved and some nurses not at all. And again, this is something that's going to be happening more often. There's a lot of multimodality therapy. There's a lot of patients coming through the department that are either on pumps or taking oral chemotherapy and body fluids. So the course, I tried to go and divide this up so that we'd be able to go and focus on what was needed at the time. Radiation safety and regulation, unfortunately, that came out of the head physicist running in the department saying, we're getting inspected tomorrow. And we all said, by who? And trying to go and have enough that we're understanding chemotherapies well enough that we can go and coordinate with medical oncology with the inpatient teams. And also try to make a resource that's available for them. All of this short videos available online on demand, something we could do health system-wide. And so I just want to say there's some benefits to optimizing the nursing role. We're here to help. The knowledge gaps are built more than just radiation oncology. I think when we're talking over 4 million survivors, over 800,000 people here being treated, we're talking about people that are going to be affected in all areas of healthcare. And I think this group already understands that quite well. And nursing education is just a critical unmet need. Thank you for your time.